I have the hip internal rotators and external rotators. For the internal, I have sartorius, glute med, glute min, and pectineus. The sartorius is from the ASIS down to the serine across here. I don't know if you can see that. Its innervation is femoral nerve. Its action, internal rotation. Glute med. Gluteal surface of the ilium to the greater trochanter. There. And that's superior gluteal nerve. Glute min is also gluteal surface of the ilium to the anterior aspect of the greater trochanter. And then the pectineus is the superior pelvic ramus to the pectineal line of the femur. Right about there. And then for internal rotators, or for external rotators, we have piriformis, gemellus superior, inferior, obturator internus, externus, and quadratum femoris, adductor longus, adductor brevis. So, piriformis is the anterior surface of the sacrum, gluteal surface of the ilium to the greater trochanter. Gemellus superior, inferior, also in this area. Obturator internus and externus from here to there. Adductor longus is the pubic body below the pubic symphysis, or adductor longus. Pubic body below the pubic crest to the middle third of the linea aspera. Here. And then the adductor brevis is the anterior body of the pubis to the inferior pubic ramus of the linea aspera as well. And then for testing them, we're doing internal rotation. And I'm going to push and she's going to resist. For external rotators, and she's going to resist me pushing out.
Okay. Very good. I've got the tightness of the IT band, and just so you know, the IT band goes from your anterior lateral external lip of the iliac spine down to your tubercle. So down here, it's going to flip it around, but you get the gist of it. It is a resisted adductor, so to do the posterior portion, to stretch the posterior portion, I would have them just hang their leg off this way, and then, and then to do the anterior portion, I'd have them, if they had space, go to the other end of the table, and then hang their leg off, stretch the anterior.
Okay. Okay, Chris. So there's some muscular attachments to the IT band also, aren't there?
Yes, sir. Tensor fasciolatum.
Okay, so when you're doing it, which way you're emphasizing its attachment from the tensor fasciolata? Should you go ahead and show me the tensor fasciolata emphasis and then the glute max emphasis? You did them both, but just identify which is which.
The glute max emphasis will be when their leg is anterior, and to do tensor fasciolata, it will be put their leg posterior to them.
Bingo. All right. Yes, sir.
All right, gluteus maximus. The attachments are the gluteal surface of the ilium, the posterior surface of the sacrum and coccyx, and the thoracolumbar fascia with the sacrotuberous ligament. So they'll go from here, and it attaches to the iliotibial tract and the gluteal tuberosity of the femur. Its actions are hip extension, external rotation, adduction, and abduction. And it's innervated by the inferior gluteal nerve. And so to test this, I'll have the patient lay prone. Have them flex their knee and extend their hip. And I'm going to apply a downward force and have the patient resist. Just like that.
Okay. And That's everything, right?
Yep.
Okay.
I have the gastroc medius and the soleus. The gastroc has two heads, a lateral and a medial head. The lateral head attaches from the posterior lateral aspect of the lateral condyle of the femur to the calcaneal tendon, the lateral side, down here, you can see that. And then the medial head is just on the medial side, going down, attaching to the calcaneal tendon. Innervated by the tibial nerve and is plantar flexion and aids with knee flexion. The soleus attaches to the medial border of the tibia, head of the fibula, and posterior border of the fibula, and it also goes down and attaches to the calcaneal tendon, so they all attach down at the same spot. It's also innervated by the tibial nerve and plantar flexus. So I have two different tests for these, so you'll probably tell me which one's better, but I just have her feet up on the table. And then, yeah, again, I'd probably raise the table actually. Good body mechanics. And I would just stabilize and push on the lateral side of her foot in the dorsiflexion and have her plantar flex against my resistance. And I also saw some people, you want to put your shoe on, they had them stand like against a wall for balance, balancing on one leg, here face the wall, yeah. Balancing on one leg, so lift that one, and they just did, you could give them like 10 sets of like 5 to 10 and see if they fatigue, and that gets both the gastroc and the soleus, but if you want to just get the soleus, you can have her bend that knee
Or it emphasizes the
to
soleus.
emphasize the soleus.
Uh-huh.
And same thing, you give them so many reps and watch for fatigue or like a difference between each leg.
Okay, so those are both good under different circumstances. So here's a huddle question, because those could both be good, but not with the same patient. So we know that that Grace is very strong and fit. So the first one, Lauren, and Lauren's very strong and fit too, but Lauren is not going to be able to budge it. In fact, we did a demonstration with this last semester, remember? And I would not be able to budge it. Because the plantar flexors of the ankle have such a good mechanical advantage. So again, Grace is strong and fit. So I saw you in the gym just an hour or two ago. And so in addition to weight training, what do you like to do?
Run.
Okay, so you're running. So if you were working with runners and Grace was your patient, which test would you do if, on the other hand, Grace was an 89-year-old lady? Which test would you do? An 89-year-old lady who had been bedbound because of some illness. Which test would you do? Both of them are good, but they're good for different patients, different kinds of patients. Right?
Trochanter down the patella tendon to the tuberosity of the tibia and the lateral side of the linea aspera. For the intermediates, it's just going to be like anterior lateral femur, patella tendon to tuberosity of the tibia. And medialis is going to be the intertrochanteric line, medial aspect of linea aspera, patella tendon, tuberosity of the tibia. They're all innervated by femoral nerve, L2, L4, and they all extend the knee. And then for biceps femoris, we have the long head going to attach to ischial tuberosity and down to the lateral side of the femoral head. The short head's going to attach to the lateral lip of the linea aspera down to the fibular head. And then semitendinosus will attach to ischial tuberosity to the linea aspera, or serine of the tibia. And the membranosus will attach to ischial tuberosity and medial condyle of each. And they're all, short head of biceps is common fibular nerve, L5S2. Long head of biceps, semitendinosus, and membranosus is tibial portion of the sciatic nerve, L5S2. And they flex the knee and then extend the hip.
Am I sitting up?
Yeah. So to test the vastus of the quads, it's going to have him sit on the edge of the bed, legs hanging off. No, scoot back, you don't hear this section. I'm just going to apply pressure at the ankle and have him resist
Okay.
downward force.
Now remember that these tests are break tests rather than make tests. So you want them, especially if the vasti are single joint muscles, so you want it to be completely extended and then test it, okay? And you'll have to put, with most people, you'll have to put your weight into it. And certainly, who's your partner there? Is that Jacob?
Yeah.
Yeah, Jacob's very strong, so you would definitely need to put your weight into it.
Okay. And then I'm going to lay down prone. To test the hamstrings, and it's going to have him flex his knee and resist an extended pressure.
Okay, and you could emphasize the lateral and the medial. Jacob's giving you a strong hand.
So to emphasize needle, just external rotate and apply pressure. To stress lateral, internal rotate and apply pressure.
Okay, good. Now, if I could point something out, stay here, Jacob, please. Tyler, you're good. You're okay. Go ahead. Peyton was complaining about cramps with his hamstring test that she was just doing. And not only is it more likely to cramp, but there's another reason that it's actually perhaps better to test the hamstrings in the seated position. So the hamstrings, first of all, is a hamstring a single joint or a multi-joint muscle? It crosses the hip and the knee. And so you remember, with multi-joint muscles, you want to have them in a more neutral position, right? Because if the hip is extended and the knee is flexed, then you've shortened the hamstring over both of its joints. So not only is it more likely to cause cramping, which sucks, but also you're more likely to get an artificially low assessment because of active insufficiency. So if I could show you something. Okay, so emphasize the lateral with external rotation. Ready, hold it. Ready, hold, good. And then emphasize the medial with internal rotation of the knee. Hold, okay, good. Great, thank you. So in the PCL tests are exactly the same that you do in musculo. And if you get the knee case for the test here, and you do it the way that you did in musculo, it'll be great. I just want to show you one more thing that I think is interesting, because you can palpate and test at the same time. And this is something that I would like you to do today, is palpate and test at the same time. Now, you have to have the knee flexed about 20 degrees for a couple reasons. First of all, if you have it extended, then as long as you've got the ACL intact, you can have a false negative. Because taut ACL will be really tight and rocking either laterally or medially. So you need to put the ACL in a little bit of a slack by flexing the knee. And then also, the reason that you have to have a little bit of knee flexion is right here. You see this? These are the pes sensorine muscles. So if you go into full extension, then the pes sensorine muscles go over the MCL, and you won't be able to palpate it. So for those two reasons, when you do, if you're simultaneously palpating and stress testing the MCL, you need to have it in a little flexion. The LCL, again, there's a bunch of ways to do it, but remember the LCL goes from the lateral epicondyle of the femur down to the fibular head. This one's pretty easy to do. You find the fibular head, and then there we go. So a lot of ways that you can do this, but I want you to actually palpate as well as stress test those collateral ligaments so you can feel them tighten up, okay? All right, so let's go ahead and do those two muscle tests. When you test the hamstring strength, do it in sitting, please. and that way you'll both get a more accurate reading because you're not putting the hamstring in a position of active insufficiency, and also you're less likely to have your partner cramp up, okay? Okay, and then also do these ligamentous stresses. Yes, ma'am?
How would you test the bedridden 81-year-old lady?
Oh, you could do it the first way
Which
that Lauren showed. So go ahead and, no, you're good actually. So point your foot and it's like this. So you could do that with somebody who's been bedridden and is very weak. But somebody who is strong, say that Grace was your patient and she has, suspects that she has Achilles tendonitis, or that would actually be a good example, and you're testing her plantar flexor strength and endurance, you'd have to do it in weight bearing because there's no way that you're going to be able to budge a strong, healthy person just by pushing on the plantar flexors manually, right?